Let's go ahead and get started here. Today we're going to take a look at joints and articulations. We've covered the bones, and this last portion here that addresses how the bones articulate to come together to form joints. And what? Okay, so this is fairly brief, but it does show you, give some good examples of the knee and the shoulder, for example, because those are two very complicated joints. The knee is the most complicated joint in the body, and the shoulder is this amazing structure. It gives us incredible flexibility. When you think about it, we can rotate our arm at the shoulder almost a full 360 degrees. And this is something that we can't do at our foot or our hand. The best we can do with our arm is to rotate about 180 degrees and rotate around the radius and the ulna. But we have this incredible range of motion around our shoulder that we don't get anywhere else. So take a look at that today. Anybody have any questions on anything, comments, concerns? If you were in the earlier class, I have no idea why Zoom was acting up. I do know there was an outage in the area, and that may have affected access. So I haven't checked to see if it's still going on, but I know that at the end of my later class in the morning, I couldn't get it to shut off. So this has not been a good day for Zoom. Okay. Any questions? Otherwise, I want to go ahead and, we got one. When is the first lecture exam? The first lecture exam should open up on the 22nd or 23rd this week. I'll have to look. I think it might open up tomorrow and stays open for 10 days. So, and that covers chapters 1 and chapters 2, the introductory chapter, as well as the chemistry chapter. So, let's see. Okay, I'm good at that. Okay, so any other questions? Okay, and I'm going to go ahead and see if I can get this to work for me. And everybody should see the slide that says joints and articulations. Minimize us and open this up. Well, I guess I spoke too soon on everything working right. Well, I can do it without the PowerPoints working correctly. Okay. Everybody to see the screen that says classification of joints based upon movement and structure. Everybody see that screen? Okay, good. That's great. Thank you. So now, a joint is where two or more bones come together. They have movement. They articulate. And we classify our joints based on that kind of movement, whether it is, a ball and socket type of movement, where they articulate freely or they don't articulate at all. Movement is everything here. Is there a complete range of motion, or is it an immobilized structure that does not move. That is articulations. That's one way we classify our joints, is by movement. How do they move? Structure is how are they put together? What is the structure of the joint? What's it look like? How does it work? So we have movement and structure are the basis of classifying our joints. Now, we know that an articulation is where two or more bones come together. And we have three types of joints based on movement, or rather, or articulation. Articulation and movement mean the same thing. There are three types of joints. There are the immovable joints, ones that there is absolutely no movement whatsoever. There are the slightly movable joints, and there are the freely movable joints, which are the most common type of joint in our bodies. So immovable, slightly movable, and freely movable. Now, the proper term for that is, for that type of movement, is synarthrotic, meaning no movement, amphiarthrotic, meaning slight movement, and diarthrotic, freely movable joints. Most of our joints are diarthrotic. So synarthrotic, amphiarthrotic, or diarthrotic. Synarthrotic joints that have no movement are the suture lines in our skull. That's a good example there. The mental symphysis, the junction where of our mandible, where it comes together. No movement there anymore. The teeth in our sockets, believe it or not, those are joints. And our teeth are embedded in our sockets very tightly. If you've ever had a tooth extracted, you know that you've probably heard some variation where the dentist will say, now you're going to feel a lot of pressure, but not much pain. Because to get the tooth to pop out of the socket requires stretching the periodontal ligament that holds the tooth in place. It's a deeply embedded joint. And the first costosternal joint, where the first rib articulates with the sternum, that is a joint that doesn't move. Now, all the rest of the joints in the ribs are slightly movable, but that very first one is not. That's a synarthrotic joint. Everybody thinks it's sutures in the skull as a classic. That's a great example. Suture in the skull is a great example of a synarthrotic, slight, immovable joint. Now, the amphiarthrotic joint is slightly movable. And slightly movable, the discs in the vertebrae, they move a little bit. They have some play in there. They have to, because our vertebral column is very flexible. We can bend, we can twist, we can pick stuff up, we can climb ladders. We have this great mobility thanks to our spinal column and its ability to absorb shock. So I mean, it's not as when you consider you've got all these vertebrae here stacked up on top of each other, and all the things we can do. I mean, yes, it's a rather rigid set of joints, but combined, they give you a great deal of freedom of motion. So the intervertebral discs are a slightly movable joint. The other costosternal joints, the costosternum, it's the rib, and the sternum. The rest of the joints of the ribs, where they articulate with the sternum, are slightly movable. And the pubic symphysis, the structure in the front where we have the two pelvic bones, the two pubic bones coming together and are separated by a pad of cartilage, the pubic symphysis that absorbs shock that comes up our legs. It absorbs shock in the front shock in the back goes up the sacroiliac, through the sacroiliac joint and up the spinal column. A slightly movable joint, an amphiarthrotic joint. And then we have the freely movable joints, the bulk of the joints, the shoulder, the knee, the hip, the fingers, the ability to move our fingers, the phalanges, the tarsal bones, the carpal bones can move. All of these are freely movable joints, the diarthrotic joints. So this is classifying these joints by movement. Synarthrotic, amphiarthrotic, diarthrotic. Synarthrotic, no movement, sutures in the skull, for example. Amphiarthrotic, slightly movable, the pubic symphysis, the intervertebral discs, even the ribs. And the diarthrotic is everything else, the shoulder, the hip, the knee, the fingers, the toes. Any one of those is a good example of a freely movable joint. So the synarthrotic joints, I think I mentioned this already. The bones come in close contact with each other. They are held together by very strong fibers of connective tissue. There are fibers that extend across the suture lines in the skull. The gum process is the socket of the teeth, and the tooth is held in there by a layer of connective tissue known as the periodontal ligament. And again, here we see the sutures in the skull. There's the sagittal suture, and that looks like the lambdoid suture there. And these are the sockets, the gum processes. They are immovable joints, again, connective tissue in place there. The slightly movables, the amphiarthrotics, hyaline cartilage or fibrocartilage. The ribs are attached to the sternum with hyaline cartilage. The pubic symphysis is fibrocartilage. So we have both, we have the slightly movable amphiarthrotic joints, usually held together with some type of cartilage. Hyaline cartilage at the ribs, fibrocartilage at the pubic symphysis, for example. And an example of this is what's known as a, another example of the synostosis is the joint that occurs where the fibula articulates with the tibia, the malleolus of the tibia, the lateral malleolus, the outer structure, what we call the lateral ankle, even though there is no ankle bone. The lateral malleolus forms the outside of our ankle. The medial malleolus on the tibia forms the medial side of the ankle. Now there is a ligament that holds this slightly movable joint in place. This is one of the exceptions where we're not using cartilage. We're still using connective tissue, though. We use a ligament to hold the fibula to the tibia. It's on the lateral side of what we call our ankle. There is no ankle bone, though. The location is the ankle, but there is no ankle bone. This is what's known as a synostosis. When we injure that ankle, we injure it by stretching the ligaments here. It's very rare that we have a fracture. If we have a fracture, when someone has broken their ankle, the fracture is either going to involve the tibia or the fibula or even the foot. So you see here and here. The let's see if this is going to work now. Yes, there it goes. Now it's working. Okay. So this is a sprain of the ankle. You'll notice that the tibia and the fibula, the lateral malleolus, that's a structure out here in the outside, the lateral malleolus and the medial malleolus come and land and set on either side of the talus. There is a ligament that attaches the calcaneus here to the fibula. Now, an ankle sprain can involve that one or that one. And we have the ligament attaching to the fibula here and here. So either one of those. Typically, it's, if you roll your foot on the outside, what's the weakest bone, the most useless bone in our bodies is the fibula. That's the bone on the lateral side of our tibia. The tibia is doing all the work. The fibula is just there. It forms the outside of our ankle. That's the weak side of our ankle. If we roll our foot to the outside, which is a whole lot easier to do than the inside, it's very easy to sprain, damage those ligaments there. So, because there is no bone to break. If you're going to break a bone, you're going to break the fibula, you're going to break the tibia, you're likely going to break the talus. But there is no ankle bone per se to break. Here's another example of the cartilage. Remember, this is all connective tissue. In our slightly movable joints, we have connective tissue. Here we have the pubic symphysis with fibrocartilage in between here. A slightly movable joint, the same thing in the pads of the vertebrae. Slightly movable fibrocartilage. Again, a slightly movable joint. The intervertebral disc, fibrocartilage, slightly movable, but it does give us that extreme flexibility we have as we transfer shock up our backbone, up our vertebrae, to be absorbed by these pads located here. So we've seen the immovables, the gum foci, the teeth in their socket. We've seen the sutures. We've seen the costosternal joint number 1, all held together with connective tissue of some sort. We've seen the slightly movable, the pubic symphysis, the syndesmosis at the ankle, where we have some type of connective tissue involved here. We have the costosternal joints below number 1. Again, cartilage involved. It's a connective tissue. So there's a little bit of movement here, slight movement. The freely movable joint, the diarthrotic joints, as the knee, the phalanges, the arm, the leg, most of our joints are going to be diarthrotic. We can move our fingers, we can move, excuse me, we can move our toes, we can move our knee, we can move our elbow, we can move our ankle, we can move our wrist, we can move our head. All of these things are freely movable joints. Now, we haven't given up on hyaline cartilage. We coat the end of all these bones, articulate together with hyaline cartilage to reduce any kind of friction. Bones don't like to rub against other bones. So to avoid that, we line the bone surfaces at the joint with hyaline cartilage, and we put them in a capsule. We put them in a capsule filled with fluid. So we surround the cavity where the two ends come together, two ends of the bones that articulate come together, and then we fill that with fluid. So we have a capsule. And then we have ligaments on the outside of the capsule holding everything together. Within the capsule, we have membranes that are called synovial membranes that secrete synovial fluid. Very clever, they named the fluid right after the membrane. Synovial membrane lines the inside of the capsule, secretes synovial fluid. It's like a very thick oil, if you will, a very dense oil that lubricates the joints so that they can move, and there's absolutely no friction, because we hate friction. We hate friction. These freely movable joints, these diarthrotic joints, are often called synovial joints because we have this synovial capsule with the bones that are articulating embedded inside the capsule, covered with this very dense fluid to absorb any friction, to lubricate the motion. So those are synovial joints. Every one of our freely movable joints in our bodies is a synovial joint. So we don't have any friction. We still, though, over time, have wear and tear. These joints are going to wear out over time. Given enough time, about 90% of the population develops arthritis, osteoarthritis, wear and tear at the joints of the articulating ends of the bones will create friction, and that friction will cause inflammation, and inflammation is known as arthritis, and it hurts to move bones. Now, a couple things. Cracking your knuckles does nothing to improve your chances for arthritis. In other words, crack your knuckles all you want to, you're not going to get arthritis. All you're doing is relieving the air pressure around the joint. It has nothing to do with the joint. It will not cause arthritis at all. Because 90% of us are going to get arthritis anyway from wear and tear, and many of us don't crack our knuckles. We still get arthritis too, or we will. Whether you crack your knuckles or not, it has nothing to do with arthritis. So I hope that, hope that helps you win an argument that you may have at some point with somebody. But cracking your knuckles does nothing to enhance the risk of arthritis. Arthritis occurs naturally. And it's going to affect most of us anyway, because it's all about wear and tear. And cracking your knuckles doesn't do anything to damage the joints. So, okay. So, and the other thing is, I'll just throw it out now. There's no such thing as being double jointed. Nobody has extra joints. At least I don't think anybody has extra joints. But there's no such thing as being double jointed. What a person who says they're double jointed is using the term that we all use, because what they have is extra flexibility in their ligaments and in their tendons. Yeah. One of our sons is double jointed. He can bend his fingers and twist his hand, twist his wrist around, and do all the things that someone that is extra flexible can do. But he doesn't have extra joints. No one that is so-called double jointed has extra joints. They're just extra flexible. So, okay, so movement-wise, immovable, slightly movable, freely movable. So, and the synovial joint, the synovial capsule joint is the most common joint in our bodies. Now, if we're looking at our joints by structure, so we've seen them by movement, immovable, slightly movable, freely movable. Now let's look at them by structure. The fibrous joint, the cartilaginous joint, and the synovial joint. I've already given it away because synovial is the freely movable one too, with the synovial capsule. Okay, so let's talk about the three structures. A fibrous joint, no joint cavity. The bones are held together by connective tissue. There's either no movement or slight movement. The sutures of the skull are the classic example of an immobile fibrous joint, because there are fibers that connect the sutures between they connect the sutures together in the skull. There are bands of cartilage fiber that extend across the suture lines and hold those sutures together. There are other places we have fibrous joints besides the suture line. Again, the ankle. Now that is not an immobile joint. There's flexibility there, but it's still a fibrous joint. So fibrous joints cover a wide range. Fibrous joints can be slightly movable or immovable. The bones are held together by collagen fibers, and this is a little stronger. Collagen fibers are a lot stronger than what we're seeing holding the skull together. It doesn't matter because the suture lines are, are the way the way the bones have come together, they're not going to move. Again, no joint cavity. The skull sutures, the teeth in their sockets, are fibrous joints. The skull sutures depend on fibrous connective tissue. We have the periodontal ligament holding our teeth in the socket, and we also have the end of the the distal end of the radius and the ulna. That's the radio-ulnar joint. That's the far end near the wrist. And no, that's at the elbow. It's approximately near the wrist. Yeah. The distal, I guess it depends on which way you're looking at it. Because if you're looking at the elbow, that's near you. The wrist is the far away, but it's looking at it from the other perspective. Anyway, the distal radio-ulnar joint is at the elbow. The tibiofibular joint is what I was showing you earlier. That's this thing right here, where the tibia and the fibula come together, are held together in place by these ligaments. So collagen fibers, are extensively involved here to hold these joints together. Okay, so but again, the outside of the ankles where it's going to roll over and sprain it. Okay. A cartilaginous joint. A cartilaginous joint is involves cartilage, not collagen fibers. Yeah. So we've seen that the slightly movable or the immovable joints held together with some collagen, held together with a lot of collagen. Yeah. You have flexibility or you have complete immobility. So the cartilaginous joint is a little different. It may have a little movement. You have cartilage in between the bones. You have fibrocartilage, or you have hyaline cartilage. You have the growth plates in the long bones. We haven't even talked about this yet, but in our long bones, up until age 23, we have growth plates in our bones called the epiphyseal plates. They are hyaline, those plates are made of hyaline cartilage and bone, and that's where our growth occurs. Our lengthwise growth occurs at those epiphyseal plates. And they will continue growing, long bones will continue growing until we're about 23 years old. And that's considered a joint. And so the epiphyseal plate is where these bones are growing. The long bones, the arms, the legs are growing. The rest of the cartilaginous joints are either hyaline cartilage, like at the ribs, or fibrocartilage, that the pubic symphysis and the intervertebral disc. So we're looking at this now by structure. This is a cartilaginous joint. We call it a synchondrices. We are wrapped around the we wrap this cartilage connecting the costosternal joint, the first one. We have the discs between the vertebrae, the fibrocartilage there. So we have we don't have a lot of flexibility with this. We have some. We have enough so our ribs can expand and relax. The ribs can expand and relax. So with a synchondrices, we have hyaline cartilage involved here. The epiphyseal plates are the one of the examples, hyaline cartilage. The joints between the ribs and the sternum are an example of hyaline cartilage. Fibrocartilage down here, tendons and ligaments here. Let me show you the next one. So this is the epiphyseal plate I was talking about. Here we have a femur and a tibia and a fibula from a child. Let's just say that it's a 12-year-old. This dark band that you see here, and here, and even in the fibula, that dark band is soft tissue. Soft tissue doesn't show up on an X-ray. This is a cartilaginous joint. This dark band occurs because that's hyaline cartilage. That's the remnant of the hyaline cartilage that was used as our model, as our skeleton when we were 6 weeks old after conception. Not 6 weeks after birth, but 6 weeks after conception. And this is where our bones grow. This cartilage is gradually turned to bone. And cartilage grows, it ossifies, it turns to bone. Our bones get longer. It's called longitudinal growth. Lengthwise, we have them at both ends of our bones. We have them at this is the knee end of the femur. There's a growth area up by the socket at the head. The same thing here with the tibia. We have an epiphyseal growth plate here and in the femur, and we have one near the ankle end. This is what it looks like after we're 23 years old. Somewhere in the early 20s, I was picking on 23. That's a reasonably good range there. Somewhere after 23 years of age, the growth plate closes up. We stop having longitudinal growth or lengthwise growth, and we have a scar. We call this the epiphyseal line across here. When we have the dark band there, that's the epiphyseal plate. That's because there's still hyaline cartilage or soft tissue growing in there. Once that completely ossifies, becomes calcified as bone, all we have left is this white line. There is no more growth taking place. So all we get is this. So you can look at an X-ray and tell immediately, is your patient an adult, or is it a child, or is it an adolescent? Because if you can still see the growth plate, the epiphyseal plate, then they're still under probably 20-some years old. So, and there's always going to be the exception. So, but this is usually the case. So these epiphyseal plates are considered joints. They are cartilaginous joints. These are going to go away and leave the scar behind. But up until about 23 years of age, we have this is considered a cartilaginous joint. And once they fuse over, then we have the area where the sternum and the ribs articulate with each other. That is the hyaline cartilage joint. So we go back here and we'll go back one more. So a synchondrices uses hyaline cartilage. The epiphyseal plates and the connections between the ribs and the sternum are the synchondrices. The symphysis is going to use fibrocartilage. Let me go back on here. And as I said earlier, there is no such thing as being double jointed. The ligaments and the joint capsules are extraordinarily flexible. They're stretchy. They're extra stretchy. They stretch, they give, they have more flexibility than one that doesn't. And so that's why they have the appearance of having extra joints being double jointed, the extreme flexibility that they get. So our slightly movable joints are going to be symphyses or a symphysis or a synchondrosis. I'm just getting that word mixed up. Now, let's get to the synovial joint. The synovial joint, the most common joint in the body. There is a cavity that forms between the two ends of the bones. There is a membrane that grows in there. That cavity forms the inner membrane of the cavity, produces synovial fluid. There is a layer of hyaline cartilage on the ends of the bones that articulate, but this fluid fills the cavity. This synovial fluid that is inside this capsule, this fibrocartilage capsule. And so we have great flexibility here because we eliminate the friction of bones rubbing against each other. Because, that's what the hyaline cartilage is there to protect against, bones rubbing against each other, but that wears away. But the fluid that fills that cavity lubricates that joint. It's a thick, viscous fluid that it does not allow the bones to touch. And so the fluid absorbs any friction that might occur. It has the consistency of heavyweight motor oil, if you will, or maybe corn syrup, something very thick and sticky that lubricates this. So the fluid produced by the membrane lines the cavity, and these occur at all the freely movable joints in our bodies, between the bones of the fingers and the toes, the tarsal bones, the carpal bones, the metacarpals and metatarsals, the knee, the hip, the elbow, the shoulder. All of these are what we call the freely movable or synovial joints, because they all have synovial cavities. So this shows you what a freely movable joint can do at the shoulder. You can see the range of motion that we have at the shoulder. That's a very complex joint there. We have our capsule surrounding the head of the humerus, the end of the scapula end of the clavicle, and the scapula itself. You can see where the capsule is surrounding right here. And there is the synovial fluid is contained in there and lubricating that joint, so we have an extensive range of motion. So this is a freely movable synovial joint. Okay. In addition to that synovial cavity, we have pads in here to reduce even more friction. There are fatty pads in here. There are menisci. Meniscus are pads of fibrocartilage that sit on top of the tibia at the knee, for example. And so the end of the femur butts up against those pads, those meniscus pads here. They stabilize the knee joint. They stabilize the femur. We have these pads, these fibrocartilage pads there and there. We call them the left and right meniscus. And for cartilage, we can tear them. We have them in the knee, we have them in our jaw, and we have them at the sternoclavicle joint, there at the shoulder. We also have sacs of synovial fluid. We call them bursa. They are bags or balloons or sacs of fluid that are embedded in the joint to work as an additional friction fighter. Wherever bones and muscles and tendons and ligaments run together, we're going to have these, this extra protection with these sacs of bursa fluid or bursa sacs. And so here we see, this is the ligament right here that holds the scapula to the clavicle. This is what we call the coracoacromial ligament, because this is the one of these is the acromion, the other one is the end of the scapula, end of the clavicle, and where they come together, you're going to have this bursa. You have these bursa sacs. You're going to have these bursa sacs where the acromion comes to, as I said, where it comes together with the clavicles. We're going to have them around our knee. We're going to have a large bursa sac that wraps itself around the ligaments that extend down our arm, down what we call the carpal tunnel. And inflammation of the carpal tunnel is very, very painful. Now, these bursa sacs can become inflamed, usually from some sort of repetitive motion injury. Now, this is bursitis, so we call it bursitis. Here is your bursa sac at the knee. There's the patella right there. There's the patellar tendon. There's the femur. There's the tibia. The bursa sac is right below and in front of the knee. Constant pressure, constant use at the knee, a lot of repetitive motion at the knee will inflame the bursa sac. And it will become very painful, and it will limit motion. It can affect the shoulder. We call it bursitis. You know, this is bursitis here. Inflammation of the bursa sac at the shoulder. Constant motion, sports injuries with constant motion. Pitchers often experience bursitis later in life. You know, someone who does a repetitive motion action with their forearm. We used to call it tennis elbow. You know, the constant motion of the forearm. Perhaps you're painting a structure up and down, up and down, up and down, up and down, or you're using a keyboard constantly. The constant motion of the wrist and the forearm inflame the bursa sac that wraps around the ligaments of the forearm. We call it carpal tunnel. You know, repetitive motion injuries. People that work in factories that do the same thing over and over again. Meat cutters, for example, in processing poultry. I used to live in Virginia near where they process lots and lots of turkeys. 30 or 40 or 50,000 turkeys a day would go through these factories, and they would be processed, particularly before the holidays. And if you're a meat cutter, you do the same type of action with your arm for 8 or 10 or 12 hours a day with overtime, or maybe not with overtime. And you end up with what we call a repetitive motion injury, where you inflame the bursa. Very painful process. It recovers with time and rest, which a lot of people that are working in meat plants don't have the time to do that. So it's a very it limits your range of motion. It's very painful. And it takes a lot of anti-inflammatories and mild exercise and warmth, heating pads to get over it. So, but it's an inflammation of these specialized sacs. Those sacs are designed to protect the joint from extraneous action. So, and they ultimately end up becoming inflamed. Now, our knee is the most challenging joint in our bodies. It is the most complex. It is the largest diarthrotic joint. It's a hinge joint, but it's also a gliding joint and a rotatable joint. It doesn't like to glide very much, and it doesn't like to rotate much. Mostly a hinge, but it will slide a little bit. It will rotate a little bit. Doesn't like to be challenged, though. It has, the knee itself actually consists of 3 different joints. It is the conjunction of the patella and the femur, and it is the conjunction of the tibia and the femur at 2 different locations. It is not a true synovial joint in the sense that it's not completely surrounded by a capsule. It's only surrounded on the sides and the back. It's not surrounded on the front. So it's only a partial synovial joint. But we have great movement at our knee. It's mostly a hinge joint, but it can slide a little bit forward or backwards. It can slide a little side to side. But when I say a little, I mean a very little. Now, so here we have our diarthrotic synovial joint. What you're seeing here is the patellar tendon with the patella, the kneecap right there. There is the end of the femur. This is a meniscus. That's a meniscus. This is you have the medial meniscus and the lateral meniscus. The fibula is always on the outside, so they always tell you that's the lateral side. So this is the lateral meniscus here, the medial meniscus here. And of course, there's your femur right there. Now, what else can I show you? Well, there is a very important ligament, the anterior cruciate ligament, the ACL. We hear about this all the time as a sports injury. That ligament gets torn and damaged when the knee is forced to hyperextend. It does not like to hyperextend. The anterior cruciate ligament, it crosses over the posterior cruciate ligament. The word cruciate means cross, and when the 2 cross over, they form the shape of a cross. That's where the term cruciate came from. The anterior cruciate ligament attaches at the front of the tibia and attaches in the back on the posterior side of the femur. The posterior cruciate ligament essentially does the opposite, attaches in the back of the tibia and inserts on the front of the femur. Okay, so there's the patellar ligament. Again, this is the femur here. This is the medial condyle, the lateral condyle, the medial epicondyle out here, the lateral epicondyle over here. And of course, there's the fibula down there and the tibia here. The ACL, the anterior cruciate ligament, attaches the anterior area of the tibia, the anterior intercondylar area, meaning the area between the condyles on the tibia, right here. The ACL connects the front of the tibia to the lateral condyle of the femur. So it attaches in the back. And this keeps the knee from sliding forward, hyperextending the knee. That's what the role of the ACL is, to keep the knee from hyperextending forward. The PCL attaches at the back of the tibia and extends to the front up here to the medial condyle of the femur. And this is to keep the tibia from going backwards. So both of these are very important. The ACL seems to get the brunt of the injuries and sports injuries. We We hear about a torn ACL all the time. Because we seem to like to hyperextend our knees. That's what happens when we tear the knee. Tear this now. ACL injuries right here. There's the ACL, and we tear it when we hyperextend the knee, and we have to have it surgically repaired. Now there's the posterior view. There is the PCL. The PCL attaches to the medial condyle. The ACL attaches to the lateral condyle. See how they cross over right here. And of course, there's the two menisci, medial and lateral menisci. So femur, PCL on top, ACL underneath. There is the lateral collateral ligament. It's on the lateral side. That's why it's the lateral collateral or the fibular collateral ligament. The lateral meniscus, the fibula. If it's on the side of the fibula, it's got to be the lateral meniscus, the lateral ligament. Fibula is always on the outside. There's the tibia. There's the medial meniscus. There is the medial collateral ligament or tibial collateral ligament, either one. Patellar ligament, femur. I'm sorry, tibia, fibula, lateral collateral ligament. There's the femur. What was I thinking? So again, we know that these ligaments here are. This ligament is the only thing holding the fibula in place. The lateral collateral ligament is the only thing holding the fibula in place at the end closest to the knee. At the other end, you have those ligaments there at the talus and the calcaneus, attaching the lateral malleolus to the talus. That's all you got, and to the calcaneus. It's all you got holding it in place. This bone, this fibula, is useless. It's the one that gets, well, I don't say it's useless, but it's useless. It breaks. It's the one that we break when we go skiing because it sticks out there by itself with no protection, and it doesn't do anything for us except get in the way. It doesn't support anything. The tibia does all the work. The fibula is out there just getting in trouble. When we dislocate our knee, it pops out of alignment. We can reposition the joint. It may need surgery to be fixed, but it can pop back in place if we'll see. So now, why do our knees hurt? Our knees hurt because the condyles of the femur rub against the meniscus pads on the tibia, and they wear away, and then we start having wear and tear of the condyles of the tibia and the femur, and we generally, if we've had a lot of motion, a lot of activity, generally we see we have to get our knees replaced. And what happens with a knee replacement is very straightforward. The damaged portion of the knee is removed. It's cut away. There's our knee. Now we see the wear and tear occurring over time. We surgically remove the worn bone. We slide the patella out of the way. We remove the worn areas here, and we add synthetic inserts. We replace the meniscus pads on the tibia. We replace the medial and lateral condyles and epicondyles on the femur. There's our condyles on the tibia. There's our meniscus pads there. On the round structure is placing the medial condyles and lateral condyles on the femur itself. And we slide everything back in place. We put the patella and the ligament back in place. And now we have a complete range of motion we didn't have before. You know, we did when we were younger. Many people have had knee surgery and had their knees replaced. It's not a difficult procedure. I've known many older people at church that have had this done, and it is, you know, an amazing procedure. It simply enhances the quality of their life tremendously, particularly if they have their knees done and then their hips done. So it's just because we do wear out. You know, our bones wear out, particularly if we're active a lot. You know, the downside of being active is you have a greater risk of, you know, wear and tear arthritis. So, okay. Knee replacements have, you know, there's a component to replace the condyles of the tibia and the epicondyles and the condyles of the femur. You replace the meniscus with this plastic insert here. And then, of course, the patella is still held in place with the patellar ligament. And the medial and lateral collateral ligaments are not removed, by the way. You're not moving those. You're only pushing them aside long enough to repair the damage and put in the replacements. Hip replacements, pretty straightforward also. The typical hip fractures occur right here at the neck of the femur, usually from osteoporosis wearing away the bone underneath. And the treatment is to remove a portion of the head of the femur, maybe down into the shaft, and also replace the acetabulum with an artificial socket, something like this. Here you see an X-ray of a portion of it cut away. The shaft of the artificial hip goes down into the shaft of the bone. It's super glued and wired in place. And again, the range of motion that you get back is tremendous. Depending on the length of the stem, it determines how far down you go and how much you're going to cut off of the worn away bone. Either the result of a fracture or just wear and tear. You know, it used to be, if you go back 50 years ago, more or less, that if grandma tripped in her kitchen and broke her hip, she would likely be dead in 2 weeks. Because what the conventional wisdom 50 years ago would be, if a person breaks their hip, put them in surgery, wire up the hip, and put them in a body cast, from the waist down, to let that bone heal up. But in many cases, grandma would be flat on her back in the hospital bed, and she would start aspirating fluid into her lungs, and she would get pneumonia, and she would die from pneumonia, usually about 2 weeks after the accident. If she survived, then she had a pretty good chance. But many individuals die from pneumonia, from fracturing their hip and having the surgery. The procedure that happens now is if grandma falls and breaks her hip, and really she's usually only breaking the neck of the femur, is to go in, cut off the head of the femur, put the artificial hip in place, put the new acetabulum in place, and put it all back together, and have her up and moving in a day or two, maybe the next day, have her up and moving around every day going into physical therapy, get her out of the hospital after 3 or 4 days. Usually she'd be on grandma was on a walker for about a week, a cane for about a week, and then on her own. And that's usually the case. So, and the mortality rate of people that die from broken hips has dropped drastically. So, but that was conventional wisdom. 50 years ago, you had a fracture, the orthopedic surgeon had to put the hip back together again. And then, what did you do? You put, if you've ever had a fracture, you know you go to a cast. Well, the hip fracture requires to be immobilized and, flat on your back. Well, that's not conducive to good health. So, only because of the risk of developing pneumonia. So, and we see what they look like. Full range of flexibility here. You can see just how far down the shaft they go. They can be held in place, as I said, with super glue and wire. Sometimes, usually they do one and the other. This one looks like it's a candidate for the procedure again. So frequently, a lot more older females have this than older males, simply because the female, once she hits menopause, she stops producing so much estrogen, and that's what happens. The lack of estrogen, without estrogen, you don't stimulate growth hormone for bones, and you don't stimulate osteoblast activity. So your female is more prone to the hip fracture than the male is. Doesn't say the males can't, but the lack of estrogen works against good bone growth. And most people like their hip replacements, but anyway, that's for whatever, take it or leave it on that last one though. So, okay, that finishes up everything on bones and joints and articulations. We've covered the bones of the skull, we've covered the axial and appendicular skeleton, and now joints and articulations. I've posted the list of all the bones and joints in eLearn, and that's essentially your study guide. You'll be able to identify the lists of the bones in the list. Now, I sent you a link for a very good interactive process, an interactive study guide called the Bone Box. It's developed by Loyola University of Chicago, and they call it the Bone Box, but it lets you go through and quiz yourself over and over and over again on the bones of the skull and the arm and the leg and the vertebrae and the pelvic girdles, and the hands and feet, stuff like that. So it's a very, very good learning tool. And the way to learn these bones and these structures again and again is through constant repetition, but a little bit at a time. If you start with the bones of the skull and work all the way through to the metatarsal bones in one time, you're not going to remember them. You have to do a little bit every day. Add a little bit more to your knowledge every day, but quiz yourself constantly. Quiz each other, quiz somebody. Teach it to your dog. Teach it to your children. Teach it to your spouse. Talk to the mirror if you have to. But again, the way you go over it, the more ways that you can find to go over this material, the more ways you're going to remember it. It really is just plain old memorization. So, any questions on anything? Okay, then I'm going to get us out of here. And I thank you for your patience earlier. Today has not been a good day for Zoom, so I don't know why. Anyway, I will see you all later in the week then in the lecture.